Thank you so much for the invite, Stephanie, and I really appreciate being here. And good afternoon, everyone. It's hopefully there'll be some useful information. Basically, my presentation, and can everyone hear me? Okay, good. Good. So basically, for my presentation, we're going to be going through kind of an overview of current scleroderma treatment, some treatments on the horizon at large, and then some treatments on the horizon at the University of Chicago as well, with a brief discussion about our planned Scleroderma Center at University of Chicago as well. One sec. Now let's use. All right, we're just going to get to the computer. So that's really our objectives for today. And to start off, we're just going to kind of, again, have this brief overview of scleroderma. So like many of our rheumatological conditions, we don't fully understand what's going on in scleroderma. We have part of the idea, and that's part of the reason why we are still having these evolving treatments, because in order to really treat the condition, we need to fully understand what's going on. So there's been progress made, but it's definitely still a work in progress. But there's clearly an autoimmune basis of this condition. It's not the full story. There's also a fibrosis pathology that's unique to this condition. And there is great vascular dysfunction. And this is just kind of a general overview. So we don't really know what causes scleroderma. We know it's probably some genetics. There's probably maybe some viral-induced or infection-induced process. And whether autoantibodies are causative or just kind of a sign of scleroderma is also still less clear. But you get endothelial or blood vessel cell dysfunction. That's part of the Raynaud's, part of the high blood pressure and the pulmonary vasculature. And you have an autoimmune component, so B cells and T cells, along with plasma cells, which are like these antibody factories. That leads to fibroblast activation, and that's kind of the cell type that puts down all the scar and skin thickening in the lungs and in the skin, and that's kind of that process. There's cytokines, which are just some molecules that the immune cells make to help communicate with each other, but they have some pro-inflammatory effects, and just some general immune dysregulation. All of these kind of pathways are important. We just don't completely understand how all of them link together. And for systemic sclerosis or scleroderma in particular, there's really three main classification systems, and they're important because there's different themes. These are not absolute whatsoever. Limited and diffuse refers to the degree of skin involvement, not how serious the condition is, but limited in general. So the key is it doesn't go past the knees or the elbows, and also would not involve the trunk. That the face can be involved in either. Limited in general tends to be more vascular, so worse Raynaud's, worse pulmonary hypertension or high blood pressure in the pulmonary system, while diffuse is more fibrotic. So there's more lung disease and there's more skin thickening. These are just, again, rules of thumb, they're not absolute whatsoever. And in general, diffuse tends to be very aggressive initially, while limited tends to be more slowly progressive, but tends to kind of be consistently progressive, while diffuse, usually our thought is after the first couple of years, things can quiet down. There's also a less common type called sine scleroderma, where you still have the condition, you just don't have to have the skin thickening, but you still have the Raynaud's, you still have the organ involvement. And there's also some antibody profiles that are again, not absolute, but they are, more so tied to these kind of phenotypes. Limited tends to be more so associated with centromere, while SCLC70 tends to be more associated with diffuse. And we kind of already talked about the rest of this. And so the next part of my talk, we're just kind of going to go through the main manifestations of scleroderma. So there's several skin manifestations that we can see. This is some typical sclerodactyly, or skin thickening on the hands, where the skin's kind of tightening up. The skin gets a little bit shiny because it's all thickened. And because the fingers can unfortunately have these contractures, these are just like from friction. These are a little bit different than the ulcers that occur from Raynaud's, which tend to be more in the tips. But this is pretty common. And there's something called the prayer sign, where again, earlier on, people kind of can lose a little bit of the ability to flex their fingers, so they can't fully flatten them out, so they kind of get stuck that way. So that's called the prayer sign, where you can kind of see in between the fingers. In our patients with darker skin and scleroderma, something that's often missed and is definitely a manifestation of scleroderma in darker skin types is what's called salt and pepper changes, where you kind of get these little like areas of loss of pigment on the skin. I have several patients where people thought this was vitiligo, which looks pretty different. This is more like speckled, while vitiligo has more like smooth involvement. But I've had several patients where, my doctor said it was vitiligo for years, but this is common in darker skin types. You can also get telangiectasias, which are blood vessel dilations, often on the face, but they can be elsewhere as well. And then calcinosis is another troublesome skin manifestation, where you get these calcium deposits that can be very painful. Sometimes they're also completely, they don't cause any symptoms, but in many patients they do cause a significant amount of discomfort. And you can kind of see on the x-ray that you can kind of make them out. So these should pop up in x-ray. And there's several gastrointestinal manifestations of scleroderma. There's something called GAVE, or gastric antral vascular ectasia, which is basically these very dilated blood vessels in the stomach. There's also esophageal dysmotility. So reflux or GERD is extremely common in scleroderma patients and can be very severe. People can have intestinal dysmotility, where it's kind of the same thing in the esophagus, only further down. That, which we'll talk about, can be very hard to treat, but basically the intestines stop having their normal contraction and people can get very malnourished as a result. Same thing in the stomach, or gastroparesis, and again, both of these kind of combine to contribute to severe malnutrition. This is an example of GAVE. So this is actually quite treatable, but it's also termed watermelon stomach, but you have all of these like dilated blood vessels in the stomach. And these can cause significant GI bleeds over time. Lung involvement's another important major organ manifestation of scleroderma. So people can both have lung disease in the actual tissue, so that's considered interstitial lung disease, where it's actually the lung itself, or people can have involvement in the pulmonary artery. That's more of a vascular issue. And it gets a little bit messy because bad lung disease causes pulmonary hypertension or hyperpressures as well. But you can have both, you can have one, but both of them cause a lot of shortness of breath. And this is an example of pretty significant interstitial lung disease. Not every single case is anywhere near as clear as this, but on the right-hand side, that is essentially a normal CAT scan of someone's lungs. That's basically how they're supposed to look. And this is very advanced fibrosis and inflammation in the lungs. Pulmonary arterial hypertension, or high blood pressure in that vessel, is also a significant issue. We've made a lot of progress treating this in general, and this also exists outside of scleroderma. It is thought to kind of be dysregulated division and growth of the smooth muscle and endothelial cells, where kind of the blood vessel starts closing off, and that is kind of what's causing the high pressures, because blood can no longer pass through smoothly. There's several treatments aimed at keeping that blood vessel open, but this can also cause a lot of significant shortness of breath in scleroderma patients. In the kidney, this is a very rare manifestation, but there is a condition called scleroderma renal crisis that generally presents with very rapidly elevated blood pressures. You get significant kidney injury, and people can end up in dialysis from this. It is pretty rare, and we'll talk about we're much better trying to prevent this, but this is something to be aware of as well. And part of the process, and this is what's shown on the picture here, the blood vessel kind of just, again, has all this growth in it. It closes off, and that ends up actually, like, it's so narrow that your red blood cells kind of break open from all the friction. So that's kind of showing the blood cells, depositing in the blood vessel. Cardiac is another probably underdiagnosed serious organ involvement of scleroderma. You can have myocarditis, which is inflammation of the heart muscle itself. You can have pericarditis, which is inflammation of the sac around the heart. And over time, what can happen in patients is the heart can kind of be replaced by that fibrotic process elsewhere. And fibrotic tissue in the heart leads to arrhythmias or abnormal heart rhythms. And the heart can also no longer pump as well because it's been replaced by fibrotic tissue. Some of that's probably the scleroderma itself, some of it's the myocarditis. There's also some vascular dysfunction as well. So this is probably missed until it's, in some patients, until it's very, very progressed. And it's probably a underreported manifestation overall. There is muscle involvement rarely in scleroderma. There are some cases that have overlap with inflammatory myositis, which is inflammation in the muscles. There's a couple of antibody types associated with that, but you can see it's very significant weakness in the proximal or these big muscles like the thighs and the upper arms. And on MRI, this is just showing all this white inflammation essentially. And then Raynaud's is another very, very, very common with very wide range of severity, but very burdensome to patients. This is kind of our classic Raynaud's phenomenon where you have at the ends of the fingers these color changes, and you can have associated pain and disability with this because they oftentimes hurt. And we live in Chicago, Wisconsin, etc. It's cold, so it's definitely burdensome, unfortunately. And this is more on the mild spectrum. People can also have ulcers that develop from not getting enough blood flow to the tips of the fingers, and that can be very debilitating. And in general, compared to say 20 years ago, we've definitely made progress. Though I would say out of our conditions in rheumatology, scleroderma probably has the biggest need for better and better treatments. In general, there's no one size fits all for scleroderma. We really treat based on what is kind of going on in that particular patient. And it's really treated by what organ, essentially. And so skin thickening is, this is what the disease is named for, scleroderma. And, this can be very debilitating for patients. And we do have treatment options. Honest truth, none of them are that great. This is definitely an area that we really need better treatments. But there is some data for methotrexate, which is a pill, and along with mycophenolate. They work so-so. Some patients, they definitely do help, but there's definitely a significant amount of patients that do not. There's a little bit of data for rituximab, which is this biologic that's given twice every 6 months that depletes B cells. And there's a little bit of data for tocilizumab. We'll talk more about this for ILD. That was one of the markers for its trial. It didn't meet its endpoint, so in the trial it technically didn't work. But if you ask experts around the country, they swear that in a select group of patients it actually worked quite well. That's a little more controversial though. And that's like an anti-inflammatory molecule, IL-6. There's also a little bit of data, many case reports for IVIG, which is a blood product of donor immunoglobulins. The thought, we don't really fully understand how it works for any disease, but the thought is really it kind of saturates all available targets your immune system could be reacting to and kind of blocks your immune system from responding to whatever it is attacking, essentially. Cyclophosphamide is really our historical scleroderma treatment. It's still used today, but I would say most experts use it less and less because it's one of our more toxic therapies we have available. But there are older studies that it could help skin thickening as well. But like I talked about, we really do need better treatments. Another skin manifestation we talked about, the dilated blood vessels, the telangiectasias. There's actually pretty decent laser therapy available for this. And we can see here a before and after, so before top, after bottom, before left, after right. So that looks pretty good overall. So If it's something that's cosmetically, not comfortable for a patient to have, or people, if they're very, very large, it can be a little bit uncomfortable as well. There is a decent treatment available for this with like a dermatologist. They can kind of burn off the blood vessel. Calcinosis is another big area of unmet need. It's really controversial how to treat this. And you can use this medication called sodium thiosulfate. Some people have it compounded and just rub it in to the areas of calcinosis. Some patients I've had experience where it worked, others it didn't do anything. It's a very slow medication as well, so like you have to give it like 6 months plus. But the idea is it kind of slowly will diffuse into the calcium. Sodium thiosulfate will bind the calcium, and the idea at least is to slowly dissolve it, basically. Some people, I don't personally do this, but some people do injections of it directly into the area. Not expecting it's very painful. There's a little bit of data for minocycline, which is actually an antibiotic, but it has these general anti-inflammatory properties. There's some exciting reports of tofacitinib, it's a JAK inhibitor. It's also being studied for scleroderma at large, but out from the myositis literature mainly. So myositis is there's definitely, like I mentioned, there's this overlap sometimes, but myositis also has calcinosis. And at least in myositis, it's helped those patients. This is very difficult to actually use in real life because the reality is, unfortunately, insurance companies do often dictate care. And because it is not FDA approved, nor has it even been studied and for this exact purpose in scleroderma, it's almost impossible to actually get approved. Some people do surgery to remove them. They often come back, but sometimes people have very large collections like in their thigh, for example. Some debulking can be helpful, but I wouldn't say it's routinely done. GAVE, like I alluded to, it actually is treatable. So for people who are having a lot of significant GI bleeds, so people can have these bloody stools, arterial stools from like the bleeding with blood vessels so close to the surface, because you can imagine that's not a great place for those to be. The stomach's very acidic. You can actually also, similarly, kind of on the face, you can kind of burn them off with this laser. And sometimes treating other organs actually helps GAVE as well. It's not entirely clear why that is, but it's sometimes, let's say, for example, you have bad lung disease, you get mycophenolate, sometimes the GAVE gets better too. And this is kind of a before and after. So this is the GAVE before. Of course, there's some scarring. This is like right after the laser. And then this is the after. So this is still done routinely if someone's having significant GI bleeds from this. As far as dysmotility, this is another one of those areas where we really need better therapies. For reflux, we can handle that. People are often on a pretty high dose proton pump inhibitor or PPI, so that's like pantoprazole, esomeprazole. These are pretty common medications in the general population. Lots of people have reflux, but in our scleroderma patients, we're often going to like twice a day instead of just daily. And then, lifestyle can also help as well. So, everyone has triggers, being up right after eating, not laying right down after a big meal, etc. Where we get into trouble, though, is where dysmotility goes lower than the esophagus or is very, very severe. There's some pro-kinetic drugs. So you can use metoclopramide, and then one of the newer ones is procalcipride, or this is called Micheal. I think the brand name is Micheal. And then erythromycin used to be used. It loses efficacy over time as well. And then pyridostigmine. But none of these work that well. There's some evidence that IVIG has been helpful to improve motility in the gastrointestinal system, but it's really just limited to case reports, essentially. And another thing that's also hard to actually get set up in real life is because it's an expensive medication and it's hard to actually get it approved sometimes, but there is a little bit of data for that. As far as this motility further down, in more mild cases, just general Miralax, high-ethylene glycol would be helpful, or just general laxatives. If you're someone straining to have a bowel movement, that you want to kind of act earlier and make it so there's no straining involved. This prolonged dysmotility can actually convert to like a lot of bloating, diarrhea, belching, and this is usually in the setting of what's called small bacterial overgrowth. So essentially because nothing's really moving around, everything just kind of sits there and the bacteria kind of build up. And so this is pretty treatable, at least initially, but we usually give like a course of antibiotics to kind of clear out the bacteria, and that can be very helpful for symptoms. And sometimes in very severe cases, this is again not at all common, but we do have patients because again, our agents are not that effective overall. We need a lot better ones. But there are patients that need IV nutrition or TPN essentially, because what can happen, the gut really just completely kind of stops working. So there's not even really any great use in like a tube feeds, for example, because just the intestines just don't contract anymore. So then we do sometimes convert to IV nutritional support in order to help prevent people from getting too malnourished. Muscle involvement is possible. It's usually with some antibody that's associated with overlap. Myositis is also making great strides. Another one of our more severe dermatological illnesses. And IVIG, which I alluded to before, that's really been kind of the standard of care. I think it got FDA approved a couple of years ago. And so we would generally use that in some ways overlap. And then other therapies as well. But kind of what's predominant. If it's myositis predominant, we're going to treat it like that. If it's scleroderma predominant, we're going to treat it like that. But there's often some overlap. Renal crisis, really the key is prevention. So scleroderma is unique compared to other things in rheumatology. We don't really use steroids for the most part, with some exception. It gets a little bit dicey if, again, someone has a lot of muscle involvement. But in general, we're not putting patients on steroids. Part of the reason is they haven't been shown to be that helpful, but the other reason is renal crisis. So there's a clear association that high-dose steroids seem to trigger this. Not in every single person, but it's definitely a big risk factor, so above 15 milligrams. That's part of the reason that we really generally stay away from high-dose steroids, or if we do need to put someone on it, as short as possible. The other key here is recognizing it. So really, any scleroderma patient who all of a sudden their blood pressure goes up 40 points consistently, for example, we should be thinking about this, because if we can catch it early, we can prevent any poor kidney outcomes. And this is associated with RNA polymerase III antibodies. And it's mainly treated with, if someone's on steroids, you stop them right away, it's treated with this common blood pressure medication called ACE inhibitors, or lisinopril. Some people in the room may be on this, for example. Then, as far as lung disease is concerned, so for interstitial lung disease, so this fibrosis and inflammation in the lung, really standard of care, I would say, since like the 2010s has been mycophenolate. So this is a pill. You take it twice a day. Usually our goal is three tabs twice a day. And that's really become our standard of care. It's pretty well tolerated overall, and definitely, I would say, a better option than cyclophosphamide, what we would really used to use mainly. Azathioprine's another anti-metabolic drug, though it's likely inferior to most of our other options. Rituximab is also an option for interstitial lung disease. That's one of our stronger immunosuppressants. It depletes B cells, antibody-making cells. Tocilizumab is actually one of two FDA-approved therapies. It's approved for interstitial lung disease in scleroderma. That's this anti-inflammatory biologic. And the other one is nintedanib, which is an antifibrotic. That's the other FDA-approved therapy. That's also only for ILD, not for the other manifestations. And there's some data that perhaps it's a good idea to use combination therapy. That would mainly be mycophenolate plus rituximab. There's a recent trial from last year to EVER-ILD that was better than mycophenolate alone. And there's some thought about using tocilizumab with mycophenolate as well. Like we talked about, cyclophosphamide is still an option, though mostly is falling out of favor over time. And we talked about that nintedanib as well. That's mainly for the fibrosis part there. The other therapies are for inflammation. And that's kind of part of why the CAT scan is so important, because they look differently. What's known as like ground glass, where this kind of looks, for lack of a better word, like kind of like schmutz in the lung. That tends to be active inflammation that's reversible. While you have this other kind of like honeycombing or kind of more fibrotic appearance, it's much denser and it has this like almost like mesh-like network pattern. That's more of a fibrotic process. That is, our goal is really not to get rid of it because it's kind of permanent and part of the lung now. The goal is really to stop progression. But nintedanib is more so added on if someone has more of a predominant fibrotic component on their CAT scans. Pulmonary artery hypertension or high blood pressure, the pulmonary artery. This really used to be a very major cause of death in scleroderma patients. It still is, though we've made a lot of progress here. So in the 80s and 70s, this really was almost nothing to do. And part of the reason why we've made so much progress is this also happens in lots of other conditions, but there's lots of newer therapies available for this. And this is one of those times where if someone has significant pulmonary artery hypertension, I mean, my personal recommendation would, someone should probably be seen at an academic center, because really all of the major pulmonary hypertension experts are at academic centers. It's hard, it's not common enough really for a community person to do it well. But combination therapy is often used. Some of these are also used for Raynaud's as well, because again, this is a vascular process to our knowledge. And so people are often on this combination of tadalafil and ambrisentan. Ambrisentan is an endothelin receptor antagonist, so that prevents the blood vessel from clamping down. Well, sildenafil, tadalafil are in this other drug class where they cause the blood vessel to get bigger, so vasodilation. There's also options as well for these prostacyclin analogs. These are not oral. They're either IV or inhaled. And some people are on these as well, but I would say the two other pill combinations is more typical. This is more so in very refractory, severe people for the most part. Heart involvement, like I alluded to, is probably under-recognized, and there's probably a very wide severity, so very mild to very, very severe. So scleroderma can definitely cause myocarditis, where there's direct inflammatory and cell attack at the myocardium, or the heart muscle itself. And this in the literature is very unclear what to do about it. So it seems different agents that are immunosuppressive, whether it be mycophenolate, whether it be tocilizumab, whether it be rituximab, etc., cyclophosphamide, all of them have had case reports of working. There is not a single trial though. So it is unclear what the best therapy is. Pericarditis, we still kind of treat like other pericarditis. So the drugs like colchicine, naproxen or Aleve, for example. Though notably, this would be a time where if you're a scleroderma patient, sometimes steroids are used for myocarditis and pericarditis. That, for example, would be a time where we try to use less of them. And it's a great area of unmet need, because really we need to prevent aggressive remodeling of the heart. So if the heart's already very fibrotic, and you can see this on imaging, on cardiac MRI, it's very hard to treat that. And so in people who have had this probably going on for a couple of years, people will kind of present with heart failure where the heart's not pumping enough. Our cardiology colleagues treat this like other causes of heart failure, but the honest truth, there's no data this does anything. We just are kind of hoping it does, because patients like this were excluded from those trials. But it's very refractory, and it's very, very hard to address, especially someone who's having a lot of arrhythmias because the heart's just kind of replaced by scar. Raynaud's is, again, one of our more typical manifestations. Really the best thing for this is lifestyle. And so whether that be gloves, cold avoidance as much as possible, hand warmers, upgrading for a heated steering wheel, really keeping the hands warm is often very possible. I've had to write some notes for people to let them have a little heater at their desk if they're in a desk job. So those kind of things can be helpful. And I would say the majority of Raynaud's responds pretty well to therapy. It's really the small segment of people where it's very, very, very severe and refractory. Really, the next step would be calcium channel blockers, which are often used for blood pressure in general, so amlodipine and nifedipine. You can combine this with sildenafil, tadalafil, which are also, if you recall, also used in pulmonary hypertension. There's a little bit of data for fluoxetine, which is an SSRI that's used for depression and anxiety. There's a little bit of data for losartan, which is another blood pressure therapy. And I do have a couple of patients that are still unfortunately actively smoking. That's one of the best things you can do though. If you have Raynaud's, no more smoking. That's often, even in people without scleroderma, smoking really exacerbates Raynaud's. As far as after that though, it's controversial what else to do. Some people do Botox. I've had patients who swear by it. I've also had patients who didn't help. If you look in the literature, it's very mixed. There was a recent small trial where it actually made it worse because it kind of paralyzes the blood vessel. So yes, it can't constrict, but it also can't dilate. So it's unclear if it's a sulfur or not. Some people get fat transfer where they'll have fat tissue from elsewhere, kind of transferred to the fingers. This is partially due to insulation because people will also often lose weight due to some malnutrition and how sick people can get. So there's some insulation for sure, but it's not just that. We all think of fat as this metabolically not important tissue, but fat actually makes a lot of different signaling molecules. It's a very richly active tissue, so there's probably some hormonal regulation as well. But again, mixed in the literature. Some people will do digital sympathectomy. This is usually with a hand surgeon, where they'll go in, they'll strip the finger of its sympathetic nerves. Those are the nerves that cause blood vessels to clamp down. Again, it's very mixed. There's some cases in the literature where it comes back a year later, and then people say, well, why would we do this very invasive procedure? It comes back in a year. But again, I've met some patients where it was very helpful, but it's probably very mixed and patient to patient. There's some data for Bosentan, specifically for ulcer reduction in Raynaud's. This is very hard to get though. It's very, very expensive. It's not FDA approved. It's also used for pulmonary hypertension as well. And there's also which we always have to discuss, there's a risk of potentially very serious liver injury with this medication. We probably twice to 3 times a year will admit people for epoprostenol. This is in someone who's having kind of finger-threatening ulcers from their Raynaud's, which again is very rare. This is one of those agents that will rapidly cause vasodilation. Though it's IV, you have to be actually at Chicago, be in the ICU to get it. So it's hard to really use clinically. And peripheral nerve blocks can also help. So they basically, so this is kind of along the same line with the digital sympathectomy, only they kind of block it up further. So they will inject lidocaine in the sympathetic nerves kind of going out of the shoulder, and that will temporarily at least cause them to no longer function, and that can be helpful temporarily as well. And so in general, while we've made progress, especially for cardiac, calcinosis, refractory Raynaud's, GI, we really need more treatments, and there's lots of treatments on the horizon. And so next part of my talk, we're just going to go through, these are some treatments at large, which I thought were interesting. These are all just from clinicaltrials.gov. So these are all currently active drug candidates. And why I think we should be excited about the prospect of some of these coming to market and being able to be used in scleroderma patients, only a small percentage of these are actually probably going to ever be used, because some of these are unknown, so they may cause unacceptable side effects. Some of them may not work, and then because of how drugs are developed, there's a lot of business decisions, and sometimes even if something looks promising for whatever reason, the company could go bankrupt, and then that's happened with other disease states as well, and they're kind of just lost, unfortunately. So a very small subset of these will probably get approved, but it's still exciting that we have so many in development. And we'll just go through this briefly. So this is an oral drug. It doesn't have a name yet. It just has this early in development, they just carry these numbers and letters. So it's called FT011. And so this is a pro-fibrotic pathway inhibitor, this G protein coupled receptor antagonist. And in earlier phase studies, it seemed to work. Seemed to help lung disease, skin thickening versus placebo. Seems to have some GI side effects as the most common issues. And there's a phase 3 that's planned, though not currently active. This was based on a phase 2. Glucosamab, so I'm sometimes, I guess, questions.
Are these in any particular order?
They are not in any particular order. Good question, though. Glucosamab is one of our repurposed therapies. So often in rheumatology, we'll try to repurpose another drug in a different disease state, because at the very least, we kind of know its toxicity profile, we know it's well tolerated, and the question is, well, does it work now? And so this is an IL-23 inhibitor. It's used in psoriatic arthritis, psoriasis, just some data in Crohn's disease as well. There's a phase 2 in Japan, and it's been looking at skin thickening. Anifrolumab is something I prescribe more and more for lupus. It's this type 1 interferon blocker, which there's not as much data to my knowledge about interferon and scleroderma, but it's thought to be a major lupus pathway. And this is currently a phase 3 study. They're going to be looking at lung function and skin thickening mostly. It says on the website, like I don't have direct knowledge of the trials, these are just from clinicaltrials.gov, but there is a Chicago site planned in the future. This is ixazomib. This is a proteasome inhibitor that's currently approved for multiple myeloma. This is a phase 2. Again, it's evaluating ILD and skin thickening. This is recruiting, but at Mayo Clinic in Arizona. Baricitinib is a JAK inhibitor. It's similar to tofacitinib, we talked about briefly for calcinosis potentially. There's a couple of trials. They're either all happening either in China or I think Pakistan or the other place. But they're trying JAK inhibitors in most rheumatic conditions. So hopefully more data to come about this. This is another one that just has the numbers and the letter. But this is an anti-TGF-beta3 drug. This is very early in development, but there are sites, somewhat, in the DC, Boston, Rochester, that's right, Mayo, and New York City. Nebulizumab is an anti-CD19. This is another B-cell therapy. There's some theoretical benefit of CD19 over CD20. So rituximab, CD20, this is CD19, they're both B cells. But CD19 is also on some earlier cells. So there's thought that maybe it depletes B cells better. It's being evaluated in skin thickening, and this is taking place in Japan. It's already approved here for neuromyelitis optica, which is in the multiple sclerosis family. Belimumab, rituximab. So they've tried this actually in Sjogren's, but belimumab is another B-cell drug. It's used in lupus currently. So the thought is, if combining two different B-cell targeted drugs is better, essentially. And so this is going on in New York City. It's in phase 2, and most of these trials are looking at a combination of ILD and skin thickening. They're also looking at belimumab alone. And at least per clinicaltrials.gov, Northwestern is a site for this particular trial. It's a phase 3. This is ifetroban. This is a thromboxane receptor antagonist. It's being really developed for pulmonary hypertension at large, but it's an oral drug, it's currently at phase 2. And they're looking for diffuse patients that have pulmonary arterial hypertension, essentially. There's some secondary outcomes as well. And closest sites that are currently recruiting for this are New York City, Philadelphia, Omaha, Boston, and Baltimore. Another one that just has the letters and numbers. This is a lymphophascitic acid receptor blocker, and it's thought to be involved in fibrosis. There's sites at Ann Arbor at Michigan, New York City, Boston, Philadelphia, and Rochester, Minnesota. and it's a phase 2 in diffuse. This is a drug that is supposed to inhibit the TNF-like cytokine 1A. They're also looking at this in inflammatory bowel disease like Crohn's, ulcerative colitis. There's some nearby locations, so Milwaukee, Pittsburgh, Toledo, Ann Arbor, some other East Coast cities as well. They're mainly looking at lung function. This is the last one that's at large. This is vixarelimab. This is a oncostatin M receptor blocking agent, and it's thought to be involved in itch, inflammation, and fibrosis. They're mainly looking at ILD. Per the clinicaltrials.gov site, Northwestern Glenview, and looks like a private practice in Muncie, Indiana, are both sites for this. So those are both somewhat nearby. And so now we're going to talk about some future directions that are taking place at the University of Chicago, and also one of which is mainly the stem cell transplant association with Northwestern. So stem cell transplant has been looked at already in the literature. And basically the process is they take your stem cells from the blood, they put them in storage. Most regimens involve cyclophosphamide, but then you have basically the bone marrow depleted, and then once it's depleted, these stem cells are kind of put back in. And really the thought mainly is you're kind of resetting the immune system in a way. Because again, we don't fully understand what's going on in scleroderma, but clearly this is an immune-predominant disease. And it seems to work well in the literature overall. But stem cell transplant is also a big undertaking, and there's definitely a morbidity and mortality risk with this as well. So it's unclear really who the best person to do this is. But that's one of the challenges is patients with very aggressive disease who have already are very, very, very sick will not survive a bone marrow transplant. So they would be excluded from this kind of thing. And at the same time, I think it'd be hard pressed to recommend to someone with mild disease, for example, because why are we going to do this? It's hard to find that sweet spot in someone that needs it, but is not too sick for it. And compared to some of our other studies, we know this works at least from trials. George Georges, who's lovely, he's a hematologist who just came to Northwestern. He's very interested in this. I met with him and he actually gave us a really lovely talk at the University of Chicago. For anyone at our center who's interested, he would be someone we'd refer to. So basically, I'd email him and we would go over kind of individual cases and whatnot. But he is very interested in doing this in people who are good candidates, essentially. One future study idea I have planned in collaboration with Pain Medicine at University of Chicago is using spinal stimulator placement for refractory Raynaud's, and this would mainly be refractory to our two kind of standard drugs, sildenafil and amlodipine. And so, right now, spinal stimulators, they're mainly used for refractory pain, either in people not candidates for spine surgery or in people with failed back surgery where it didn't help and they try a spinal stimulator. But there's actually a lot of case reports and some case series of this actually being very effective. They're very, very limited in number though. And the thought is basically the spinal stimulator itself has all of these kind of downstream targets. So it decreases pain because it's, basically the way it works, even though it says stimulator, you basically block the nerve that it's on. And so you got decreased pain, you get this electrical stimulation kind of going the wrong way. So instead of going towards your body, it goes down. Then that's thought to open up some blood vessels. You decrease the sympathetic systems, that's like fight or flight nervous system that causes blood vessels to clamp down. So that's decreased. And you also have this release of neuropeptides, which is thought to influence vasodilation and blood vessel regulation. So there's some scientific rationale, some case reports, but this is a planned future trial, probably be a small one. with pain medicine for people who are still having kind of unacceptable symptoms despite being on kind of our two best drugs, essentially, for Raynaud's. Another thing I'm very excited about is CAR T therapy. So this is mainly used in the cancer space right now. And essentially what CAR T therapy is it's an invasive process and a lot like to actually make them, but they take your T cells from your own yourself, and then in the lab they modify them to change their receptor. And the whole point, so in the cancer world, the receptor is changed to really target and focus on the cancer cell. This receptor is against CD19, which is, if you recall, there's actually a drug in development that targets CD19 as well, but it's against B cells, essentially. So this is a B cell depleting therapy. And there's a couple of companies doing it. One major one is Cabaletta out of Philly. We recently got confirmation University of Chicago will be a site for this. Northwestern, I believe, is going to be as well. So I'm very excited to be able to offer this to patients. And part of the reason I'm so excited about CAR T, so it works the same way as some of our drugs, but the nice thing is this is a live cell. So there's some theory that part of the reason rituximab, for example, doesn't work, or even anti-CD19, it just stays in the blood. There's a little bit of this volume distribution elsewhere, but it doesn't get in the entire body. While this isn't a live cell, they can travel in and out of blood vessels and go around, and you really probably get more potent and complete B cell depletion. So that's part of the reason why this may work better, and we're very excited about this. The main outcomes for the trial are lung disease, cardiac, renal, and skin. And this is unfortunately a very common, so this is similar to stem cell transplant. One of the major exclusion criteria is significant pulmonary hypertension. Also very significant ILDs excluded as well, but it's fairly easy to be excluded if someone has bad pulmonary hypertension. It's not a very high number to be excluded, unfortunately. And part of the reason why myself and I think scleroderma experts at large are so excited about this is, again, this is a small report, but this just came out in February. So a German group used CAR T in a variety of different illnesses. There are really the three main ones, which can be very severe, is lupus, myositis, we already talked about a little bit, and scleroderma. So they use it in all of them. There were 4 scleroderma patients that were part of this kind of more case series. And again, this doesn't mean it's going to do this once we have a bigger trial or do this in every single person. But the initial, in these 4 patients, the MRS is the Rodman skin score, that's like a measure of skin thickening. And the one up top is like a general, which includes some organ manifestations as well, like a general scleroderma severity score. But it helped. And it helped pretty rapidly. Also, all 4 of the patients stopped their other immunosuppression that they were on as well. And they also reported a couple, which I wouldn't really even expect, but the people with pulmonary hypertension, their pulmonary hypertension got better. So this is a very exciting prospect. If it does something like this in a larger population that's tested, this could really potentially be a game changer for scleroderma.
I have a question.
Yes?
Is that similar to what we've heard about CRISPR, that term being used about the genetic editing of the cell? Is it a similar kind of process?
So that's a great question. If I'm being honest, I don't know the exact way they modify the receptor. I want to say they don't use CRISPR to do this, but I'm not positive about that because they're not modifying the genome, to my knowledge, what CRISPR does. They're just kind of modifying the receptor itself, but I'm not positive about that. The other trial we have confirmed we'll be part of is this Conquest trial. So this is a national trial. I also believe Northwestern is a site as an FYI. And so this has multiple arms. Not every single site's doing every arm. We're going to do, I think there's 5 total, we're going to do 2 of them. And this is really an ILD focused study. There's a couple of secondary outcome measures. Secondary is basically like exploratory, while primary is really what you're interested in. So it's really an ILD study. And the nice thing is background mycophenolate is allowed, because that's again our standard of care therapy. I would very rarely go right to a trial if we didn't try anything. And so one of the arms that we're going to be doing is this drug called amitelimab, which is a biologic that targets this OX40L. This is a general signal that is involved in a variety of different cytokines, so those messaging molecules, and T-cell activation. That one is an infusion. And the other arm is, again, this drug only has a number and a letter. It's BL1015550. This is an oral PDE4B inhibitor. It's basically a more selective apremilast. I don't know if anyone has psoriasis or arthritis, but apremilast is used in that condition. It has a ton of gastrointestinal side effects, though. So my own experience, probably half the patients don't tolerate it due to really severe nausea, vomiting, etc. But the thought is this is selective enough where, at least in animal models, it didn't cause any GI side effects. So perhaps it's a more tolerable therapy. And that should be starting up soon. The other thing, which is also really exciting, so during my fellowship, I became very passionate and interested in helping scleroderma patients and hopefully moving the field forward. And what I think is probably clear, scleroderma is complex. Rheumatology often kind of takes almost a primary care and also immunosuppressive role, but this is a full body disease, and organ, skin, it really needs, for patients that have these complexities, a team that is familiar and kind of dedicated to helping all these different things that can happen. And so lots of centers, because of this, have really formed these multidisciplinary centers where there's, of course, room, but also other fields that are around to be able to help people when different things come up. And so as part of my new faculty position, I'll be forming our second scleroderma center in Chicago. So right now, Northwestern, of course, I believe Carrie Richardson's been here before, and she's also lovely. I know her as well. But at University of Chicago, we'll be forming one as well, which I think is really important to offer. Because geography is a big limiting factor. We also have a really at-risk population in the South Side of Chicago as well. I think it's really important to improve access, have more trial slots, hopefully, really help people and help care for patients evolve. And so basically the people, everyone's been named, it's more or less form, we just have to get some website stuff going. But these are the people that will be involved. So I'll be the main rheumatologist involved in scleroderma at Chicago. We'll have Dr. Micheal in GI, who has an interest in motility and TPN. Pain medicine will be able to offer those temporary blocks, and hopefully I'll be able to put together this biosimilar trial with them. For renal, for those people with renal crisis, we'll have Dr. Bonilla and his colleague. Stanley Swat is our pulmonary hypertension specialist. He's a cardiologist. Some center it's lung, some center it's cardiac. This really depends on the center. Plastic surgery. Dr. Undakat, again, even though it is controversial, he is interested in doing digital symphypectomies for people that decide that's something they want to do. And Dr. Hansen is interested in doing fat transfer for people that decide that's what they want to do for their Raynaud's and just try it. Dr. Hoffman will be our dermatologist, and I know Dr. Streck's been here before, I'm not sure at this exact site, but at the conference in the past. She'll be one of our pulmonary colleagues, along with Dr. Lee and Deji as well. And so really the plan is for this still to only be at Hyde Park. I will be elsewhere, but it's very challenging to offer every single specialty at every single place. So most of my colleagues will be at Hyde Park mainly. I will be elsewhere. So Crown Point's one of our newer locations. I think it literally opened up last week. I'll be there as of July, a day a week. But I plan to have most of my dedicated scleroderma clinic time at Hyde Park. So I still will be out in the community and in Crown Point. You know, depending on what's going on, it may be possible, you know, if someone needed to see me there, we could see them at Crown Point, but probably they need to see pulmonary or, you know, someone from plastics, et cetera, then they need to kind of travel to Hyde Park for those particular people. And I thank you everyone for all your attention. I'm happy to take any questions to the best of my ability, but thank you so much for your attention, and I really appreciate it.